I begin by introducing myself. I'm Dr. Rim Qalala, a dental assistant professor in the Faculty of Dental Medicine, Tunisia, Monastir. I'm very glad today to present you my work entitled Maxillary Midline Diastema, How to Deal with. So let's begin by introducing the topic. The definitions of dental beauty differs in different cultures and across time, where diastema was considered as a sign of beauty in the 1916 and the 1917s, but nowadays diastema is among smile aberrations. Studies on the attractiveness of smiles as a function of their variation from aesthetic norms have shown that maxillary midline diastema is a decisive negative factor and a strong candidate for treatment. Diastema is defined as space greater than 0.5 millimeters between the proximal surfaces of the tooth homologues of or adjacent teeth. So the question is how to deal with. Let's begin by studying the prevalence of this problem. So there is an unanimous agreement in the literature on the racial differences in the prevalence of the midline diastema. For adults, various studies reported highest percentage of diastema, which ranges from 4.46 to 28%. And these percentage varies across studies and especially across population, and varies from 9% for the teenage population to 28%. So why we observe this problem? Why we have this maxillary midline diastema? So usually we have to know that usually the midline diastema is a part of a normal dental development during the mixed dentition. However, this diastema will disappear following the eruption of the lateral or and canines, the permanent lateral and canines. However, and this is because of several factors which can be the reason or the cause of this persistent midline diastema. This variation of midline diastema could be attributed to genetic and environmental factors, age, gender, or sample size. So, according to Abdallah, the midline diastema is a clinical sign which has a multitude of underlying etiological factors. He classified the etiologies of the maxillary midline diastema to major etiological factor and less prevalence factor. So we can summarize these factors in for, of course, adult patient to mainly the prominent labial frenum. It means that the labial foramen, which is the connecting tissue between the upper lip and the gingiva, it is unusually thick or extends too far down in the maxillary teeth, and this frenum prevents the connecting of the maxillary incisors. This midline diastema can be also observed because of the tooth size discrepancies. It means the teeth are very small in a very large jaw, or we can be observed also when we have big-shaped lateral incisors, and also in cases of the agenesis of maxillary lateral incisors. Other factors can be highlighted, which are the physiological development, genetic factors, especially from parents who have maxillary midline diastema. We observe generally children have this dental problem. Also supernumerary teeth, so the presence of an extra tooth like the mesidens between the central incisors can create this space between the central incisors. This problem also can be due to the oral habits. So persistent habits like thumb sucking or tongue thirsting can exert pressure that gradually widen the gap between maxillary central incisors. And of course, the periodontal disease in advanced cases can lead to this the maxillary midline diastema. So the question here, how to manage with the patients who are looking to close this maxillary midline diastema, who these patients are bothered from the aesthetic appearance because of this problem. So we have to know that the aesthetic treatment of maxillary midline diastema is very challenging task in dentistry. The treatment, of course, should not seek to manage only the diastema, but we have to seek behind it, or at a first step, the cause which leads to the maxillary midline diastema. So we have to treat the cause and to manage with the maxillary midline diastema. So here, the patient's need, demands, and expectations must be considered in the process of the treatment planning to ensure his satisfaction in the for the last result. So we have to take into consideration when treating this midline diastema, the diastema size. We have to take into consideration the proportion of the teeth. We have to take into consideration the occlusion and also the anterior guidance, as the maxillary incisors are the responsible dental units for the anterior guidance. So here we have to mention that particular attention should be given to the ratio of the central incisor, which should be respected. So she reported ratios from 75 to 85% are the ideal ratios for maxillary central incisors, which are considered the most aesthetic. And if the spaces are wide, the teeth will appear disproportionate and short after the diastema closer. So this apparent height to width ratios can also manage it in some situation by artistically controlling reflective and deflective surfaces, which is called the illusion, optical illusion. It means when the surface is very flat, so the deflective surface is more important, and the tooth will appear longer and wider. However, if the surface is more convex, so the deflective surface will be narrower and the tooth appearance will be narrower. So also here we have to learn or to know about the line angles, which are a very important structure that we can manage with for the optical illusion. And as we can see here, for this rectangle and the second rectangle, so the second one, we can say that this rectangle appears longer than the first one. And this is by controlling the line's angle. Here we have placed the line angles here. So as we have said, the reflective or deflective surface is narrower and the tooth will appear longer. And also from the proximal angle, also the rounded incisals angle here, as observed here, create an optical illusion that causes the tooth to appear narrower. So by drawing the eye toward the center of the tooth. So how to manage with maxillary midline diastema? We have mainly three therapeutic options, which are the orthodontic treatment, resin composite restoration, or the veneer restoration. Let's begin by the orthodontic treatment, or the orthodontic closure of the maxillary midline diastema. It seems that the orthodontic treatment is the ideal treatment. It is the most conservative one, and it can be associated with others therapeutic option. However, this treatment is very time consuming. The duration is very important, and it cannot be indicated when the sufficient interarch space it is indicated when a sufficient interarch space is present, or in the case of layered maxillary incisors. So the orthodontic treatment can be sectional or full arch fixed appliance. But the orthodontic treatment cannot be indicated in the case of stable occlusal contacts without excessive overjet or overbite. It means when we have the occlusal contacts are correct, we have not excessive overjet, overbite. So here, the orthodontic treatment cannot solve the problem, because here, generally for these cases, the midline diastema is observed because of the teeth size discrepancy. So the orthodontic treatment cannot be the solution. And in some cases, the orthodontic treatment can be used for the space redistribution and have to be followed by other therapeutic options. The second therapeutic option is the resin composite filling. So this technique is simple, direct, no expensive, and reversible, and with long-lasting results. However, it requires a very skilled operator. So for this technique, Wild proposed three criteria for successful diastema closure: an increased emergence profile with natural contour at the interface between the gingiva and the tooth, a completely closed cervical or gingival embrasure, and a smooth subgingival margin that does not catch or shred dental floss. Let's move to the last therapeutic option, which is the ceramic veneers option, or it can be also the veneers can be performed on resin material, but here we are speaking especially about ceramic veneers. So the ceramic veneers have become the alternative to the composite restoration. So they can transform smiles painlessly, conservatively, and with long-lasting results. We have, comparing to the composite material, the ceramic material offers excellent tissue response, and good or better quality of surface. Let's move to presenting clinical cases of maxillary midline diastema. So the first case is about a 25 years old female patient who consulted our department for the aesthetic management of her maxillary midline diastema. And here, as we can observe, they have maxillary midline diastema, wide diastema, and here we have absence or missing of the maxillary lateral incisor. So we have here we have recognized the cause. So in the clinical case, the ideal treatment is the orthodontic treatment, then followed by either implant-supported prosthesis or the fixed bridges. But the patient, in this case, refused the orthodontic treatment. So here, the aesthetic treatment have to deal with both the midline diastema and have also to repair or the missing tooth, which are to replace the missing tooth, which are the lateral incisors. So the model or the impression was taken, and on casted we have performed the wax up and corrected the shape of the central incisors and replaced the missing teeth. At the stage of the mock-up, the patient was not very satisfied with the shape of the maxillary incisors, or as they was very wide, and the crown lengthening was not possible, as the overjet and the overbite was very important, so we cannot opt for crown lengthening for this patient. So we opted for the two fixed bridges in this case. The preparation was performed, the impression was taken. Here we have the virtual conception of two fixed bridges, and here we have obtained the ceramic fixed bridges, and as you can see here, we have not closed the midline diastema, all the median diastema. However, the patient was very satisfied by the final outcome. Let's move to the second clinical case, which is about 26 female patient who asked as well for the diastema closer. So the clinical examination revealed the flatted maxillary incisor with a large midline diastema. Also, we have missing lateral incisors here, and spacing also. The diastema were not only in between the maxillary incisors, but also between the canine and these incisors, and between the premolars and the canines. So here we opted for the orthodontic treatment as a first step, which is followed by aesthetic rehabilitation. So for the orthodontic treatment, we opted for the space closer, and we have managed a sufficient space for the missing lateral incisors. Here, the ideal solution was the implant-supported prosthesis, but unfortunately, the patient refused this solution, so we opted for the bonded bridge, and here we have the final aesthetic outcome, and the patient was really very satisfied with the aesthetic results. The last case is about a patient also who asked for the aesthetic rehabilitation, 25 years old patient, healthy, and she asked to manage or to deal with her maxillary midline diastema. So here, the intra-oral examination revealed that we have wide midline diastema, about 5 millimeters, a high frenal attachment between labial frenal attachment, ovale central incisors with irregular incisal edges. The overbite was about 4 millimeters, and she was in class 1 relationship. So here the occlusal context was stable, so we cannot close the diastema by the orthodontic treatment. So we opted for the space redistribution for this patient. So, and here, taking into consideration diastema size and occlusal stability, we have opted for the orthodontic redistribution, followed as well by frenectomy and ceramic veneer. So here, the orthodontic step was performed using edgewise bracket in the maxillary arch. 0.18, 0.5 nitinol wire were placed to activate the brackets. Then elastic chain between the two central incisors was placed to facilitate the diastema closure, and the patient was evaluated and seen approximately every 3 weeks, and the time, all over the time, required was about 6 months. And we have at the same time opted for the frenum labial frenectomy was performed, and until the orthodontic treatment was finished, we have redistributed the space due to the midline diastema, and here we opted for the wax-up step, the mock-up performing, the validation of the final the project for prosthetic project, the preparation was performed, and here between the central incisor, to establish here a proper immersion profile, we have merged the finish line between the central incisors. So the finish lines were placed apically, deeper, to optimize the immersion profile of the veneers. Here we opted for placing deeper the line, finishing line, to have harmonic, more harmonic, so immersion profile. Once the preparation was performed, the master impression was done. Here the veneers were obtained and were correctly bonded. So we opted for the diastema closure, the correction of the teeth shape, the optimizing of the color, and of course the patient was extremely satisfied. The bonding procedure was correctly performed using a photopolymerized rubber dam, and the bonding was correctly performed. And here we have the final result, and the diastema was correctly closed, and the patient was really very happy of the final results. So let's conclude about maxillary midline diastema. So closing maxillary midline diastema is a fairly common request of modern day patients, explaining the various treatment options to the patient and especially documenting their understanding of the options is very critical in gaining the patient's context and cooperation in achieving a result that will be judged successfully. And thank you for your attention.